question that clinicians have had for a long time is when to remove peripheral IV catheters. In adults, traditionally these have been removed at set time points, so starting even at 24-hour removal in the 1970s and slowly relaxed out to 72 to 96 hours in recent years. This policy is not always easy to implement. Many patients just don't have enough veins or are difficult to cannulate, particularly those who are overweight, elderly, or have had multiple insertions. Another issue with this policy is it does increase the number of invasive procedures. Every time an invasive procedure is performed, it's an opportunity for microorganisms to be introduced to the body, causing infection. It's also painful for patients, and it does have significant workload and costs. The reason this routine removal policy has been in place is as an opportunity to try and reduce complications, specifically phlebitis, so vein irritation, as well as bloodstream infections. Until now, there haven't been the randomised controlled trials to tell us whether this actually works or not. An alternative is to follow the removal policies that children's hospitals have always followed worldwide. So these are removal on clinically indicated reasons. So this includes when the catheter is no longer needed for therapy, so therapy is completed, or if there's any complication that stops the cannula being useful. So if it becomes blocked, if it becomes dislodged, if it's too painful, or if an infection is suspected. This systematic review was done through the Cochrane collaboration, the gold standard for undertaking systematic reviews of evidence. The authors, which included myself, went and looked for every randomised controlled trial that had been published anywhere in the world, looking at any time frame for routine removal of peripheral catheters versus removal for clinical reasons only. The method followed the strict criteria of the Cochrane collaboration to assess the studies for their risk of bias and the level of quality for a range of methods. For those of us who had been involved in the original research studies, we had no involvement in the actual critiquing of the quality or the findings of those studies, so that was done independently. The results were extracted of the studies, and then the results were put together to get an overall finding in the literature. And of course, this provides level 1 evidence, or the top of the pyramid of evidence for effectiveness of interventions. We found 7 studies published with almost 5,000 patients randomised worldwide. These studies were undertaken in India, in England, and in Australia. So nearly 2,500 patients were randomised to clinically indicated removal and the other 2,500 to routine removal, either every 48 hours in one study or every 72 to 96 hours in the remainder of the studies. The 4 endpoints that the studies looked at included phlebitis, catheter-related bloodstream infection, all bloodstream infections, and costs. The first finding for phlebitis, we found no significant difference between these 2 groups. There was 9% phlebitis in the clinically indicated removal patients and 8% in the routine removal patients, and this was not statistically different. As far as catheter-related bloodstream infections, the rates were very low in both groups, so only 1 patient had a catheter-related bloodstream infection in the clinically indicated group and 2 patients in the routine replacement group. We also looked at any cause bloodstream infections, recognising that catheters are often not cultured in PIVs, so CRBSI may not be always available as a definition. When we looked at all bloodstream infections, we found 4 in the clinically indicated group and 9 in the routine replacement group. Again, numbers were small, but certainly no significant difference and no trend of any higher rate of complications in the clinically indicated group. As far as costs, the overall costs were approximately $7 less per patient in the clinically indicated group. And the quality of the studies was ranked high for most criteria. So randomisation was done well, the random allocations were concealed until the patients entered the studies. Nearly all patients randomised were actually followed up and included in the analysis, and there was low risk of bias on all the other indicators looked at. So it's very unlikely that future studies will change the results of this systematic review, given that large numbers have been studied in multiple trials. Because the rate of infection is low, then it would need very, very large studies to further narrow this down in terms of effect. But we can certainly rule out any large effect on bloodstream infections because 5,000 patients have been studied already. So what does this mean for patients? Well, it certainly reinforces the current guidelines from the UK government, so the EPIC 3 guidelines for clinically indicated replacement to be the standard for peripheral catheters. Also, the Infusion Nursing Society's standards of practice, which are applicable worldwide, also recommend clinically indicated replacement. So as we see more and more hospitals move across and review their policies, Avatar recommends that clinically indicated replacement is the new removal policy for PIVs. We know that this is going to drastically reduce the number of unnecessary invasive procedures, and because those procedures are not always easy to perform and are not always performed aseptically, this is another opportunity to avoid a procedure which can cause infection. Naturally, this is going to be much more pleasant for patients. If a patient has a catheter that is comfortable and is still working, there is no reason to remove that catheter and then put the patient through more painful and possibly repeated cannulation attempts. Similarly, this will have a great impact on hospital budgets and staff workloads just because so many PIVs are used within the healthcare system. Future research in this area now really needs to start targeting interventions that do have an effect. So I think perhaps we've been distracted by the policies of removal at routine periods rather than looking at what we can do even before that time to keep cannulas working. Certainly, many studies are seeing high rates of failure even on day 1 or 2 of cannulation. Many catheters are placed in the first place that were not needed and are left in far longer than they are still required for therapy. So if we can now turn our attention to those interventions that reduce the risk of having any IV cannula, having an IV cannula in for too long, and also looking at what else we can do to keep those cannulas from blocking, from dislodging, and from becoming painful.